All right. Well, I'd like to welcome you to the final Columbia Ethics Grand Rounds for this academic year, which is entitled Medicalizing and Criminalizing Mental Health. I am Sandra Sujin Lee, Professor of Medical Humanities and Ethics and Division Chief of Ethics here at Columbia. For those of you who are joining us for the first time, Columbia Ethics Grand Rounds is sponsored by the Division of Ethics in the Department of Medical Humanities and Ethics here in the Vagelos College of Physicians and Surgeons at Columbia University. The goal of the Division of Ethics is to integrate humanistic perspectives and ethical reasoning towards alleviating human suffering and promoting justice and equity in scientific practice, biomedical research, and healthcare. Our faculty, staff, and students aim to cultivate a multidisciplinary community focused on ethics and to conduct innovative, high-impact bioethics research at the intersection of biotechnologies, health equity, and social justice. The theme of our Ethics Grand Rounds this year has been incarceration, policing, and health equity. According to the Vera Institute of Justice, the incarceration rate in the United States has dramatically increased over the last 50 years, growing by 400%, resulting in the highest rate of incarceration in the world. For those who are incarcerated are disproportionately people of color, immigrants, and people experiencing poverty. Our criminal justice system and the brutality of policing results in significantly higher rates of chronic disease and serious mental illness. This series centers the human indignity and societal toll that incarceration and policing has on community, family, and individual health as a critical yet neglected focus of bioethics. So in today's session, through this series, we have hoped to bring us together and reflect on the meaning of justice and consider how we as scholars, clinicians, scientists, educators, students, and more will respond in our own work. In so doing, we will interrogate incarceration and policing as an American public health crisis and ask how structures of racial inequality are created and reproduced. We ask that we consider the ways in which practices and policies concretize inequities that cause human suffering. So we have an opportunity to ask how each of us will take up this challenge, and we hope that the series has and will continue to catalyze action that will directly address incarceration, policing, and its health effects both within and outside of academia. So we have a terrific panel today, but before I turn to our speakers, I'd like to just go over some logistics for the session. We ask that all attendees please abide by the code of conduct, which you can now find in the chat. We have a live closed captioner present for this event. And if you wish to use closed captioning, please turn on the CC button at the bottom of your screen. If you do not enable the CC feature, captions will not appear. So if you do want that, please do click on that link. We will reserve the last half hour of this event for discussion. So I encourage you to use the Q&A button, which you will find at the bottom of your screen, to write in questions for the panelists. And you can do that at any point during the session. You can register your enthusiasm for a question in that Q&A box by elevating it up the list by using the upvote button. The chat box is also available for further engagement, and we will post relevant links to resources referenced in today's discussion there as well. And afterwards, you will be able to see a list of those resources with the recording that will be available. If you have any logistical questions or troubleshooting needs, please do email us at mhe_ethics@cumc.columbia.edu at any time. So now with those housekeeping details done, it is really my pleasure to introduce our speakers today. Dr. Leah G. Pope is a research scientist at the New York State Psychiatric Institute and assistant professor of clinical behavioral medicine in the Division of Behavioral Health Services and Policy Research here at Columbia University in the Department of Psychiatry. Trained as an anthropologist, Dr. Pope has extensive experience conducting mixed methods research at the intersection of the mental health and criminal legal systems. Dr. Pope is currently the principal investigator on a study of the implementation of the 988 crisis line in New York State, and a co-investigator on several studies on crisis response, including a randomized controlled trial of crisis intervention team training for police. Our second speaker is Dr. Kimberly Sue, who is an assistant professor of medicine with the program in addiction medicine in the Division of General Internal Medicine at Yale University School of Medicine. She is the former medical director of the National Harm Reduction Coalition in New York, which strives to improve the health and well-being of people who use drugs. Currently, she serves as an attending physician at the Central Medical Unit at the APT Foundation, which provides primary care to patients receiving methadone and other substance use treatment services, and supervises fellows and trainees within the Yale Addiction Medicine Fellowship Program. She also is an attending physician on the hospital-based Yale Addiction Medicine Consult Service. And finally, we have Miss Faye Owens, who is a peer specialist and advocacy coordinator at Urban Justice Center Mental Health Project. Faye facilitates 3 workshops. First, the Reentry Advocacy Workshop, which empowers people and integrates them back into society with the necessary tools to become productive. Next, Faye also facilitates the Systems Advocacy Workshop, which gives participants the language to speak with government officials in a manner with which all can understand. And then finally, Faye facilitates an open mic night with a host of her MHP coworkers that allows the communities they serve a talent-filled night of fun in a safe environment. So please join me in welcoming Leah, Kimberly, and Faye. And actually, I think we're going to start with Kim.
Thank you so much. Thanks for having me on this wonderful and really important session. So I'll just get quickly into my slides. Next slide. So I have no disclosures or conflicts of interest. And as a trigger warning, I will be discussing self-harm, suicide, and overdose for people to know. Next slide. So I love being on this panel. My bio left out that I'm also a medical anthropologist, like many of the other people on this panel and organizing this panel. So some of what this groundwork and framework comes from my ethnographic research, which resulted in my book, Getting Wrecked: Women Incarceration and the American Opioid Crisis. So this was ethnographic work that I conducted in the prisons and jails of Massachusetts. And my central question going in to my dissertation in anthropology when I was at Harvard, and thus became, and I worked into this book, was really what happens to women with substance use disorders when they go to prison and jail, because so many of our policies criminalize substance use and mental health. And I really wanted to understand what happens to women inside these spaces, as well as what happens to women when they leave these spaces, and the aftermath and imprint of that. So I used some ethnographic methods to really understand, as much as I could, the experience of these carceral facilities. So that's sort of the groundwork for this. But and then after while I was working on the book, I actually was working as a physician at Rikers Island. So I was working at Harm Reduction Coalition, but also seeing patients at Rikers Island Jail Complex. And a lot of this, what I'll present in this talk, is based on some of those experiences, as well as some of my experiences in communities and trying to think through how we can envision care outside of these carceral spaces. Next slide. So incarceration has, just to frame this discussion for you, has many harms. And these are not only physical, mental health harms, but also social harms. Some of these are, include violence, so physical threats to people's imminent health, withdrawal from substances, opioids, benzos, and alcohol. So we know that those can all be very painful as well as possibly fatal. Disruptions to medical care that people may be having in the community, Medicaid suspension, so loss of access to insurance, loss of housing or employment, and risk of self-harm. So these are some of the common harms that we see with incarceration. Next slide. And, here I want to posit kind of a humanizing aspect to some of the harms that happen. This is a suicide note that Segundo Guiapa, Ecuadorian immigrant who was living in Queens at the time, etched into the wall to his wife before he died by suicide at the Rikers Island jail facility. So going through the numbers of people that and their stories that have died at Rikers Island in the last year are horrific. There are deaths by suicide and there's deaths by overdose. These are largely preventable, treatable conditions that we see and take care of in the community. And the context is, full of stress. We know that correctional officers weren't doing their jobs. They're faking the logbook, saying that they were rounding on people when they weren't. So there's a lot of structural issues that have led to the tragic deaths and preventable deaths of many people. And you can read about those in several of the news outlets about the deaths that continue to occur at Rikers Island and are truly preventable. Next slide. So again, there's harms associated with leaving prison and jail, and one that I'll point to is the risk of harm from an overdose death upon leaving incarceration. This is a New England Journal paper that is seminal. It's pretty old, but it's seminal in pointing out that the risk of overdose death in Washington State for people leaving prison and jail was much higher from opioid overdose. And this is like the pre-fentanyl era that we're now seeing. If we recreated this study, I think that we would see, similar rates of overdose and death. And this study actually pointed out that there were many other harms that were not only overdose, but risk of morbidity and mortality from heart attacks, from interpersonal violence. And so these are the kinds of disruptions that are caused by someone coming in and someone going out and not having that kind of care that they need, that kind of social support that they need. And, I've documented, I also added on here police violence, which I think we'll talk a little bit about, but for many of the people that I know and work with, they get assaulted or harmed by police from the moment that they encounter police. Next slide. So a little bit of zooming out and thinking about ways that we can pose, use theory to think about different ways that we can envision care outside of a carceral context. So one is, using the lens of stigma and thinking about the numerous ways in which people with mental health conditions or with substance use disorders are stigmatized and are unable to access the care that they need. Thinking about structural violence or the conditions under which people live in our social hierarchies and orders that I'm not going to say dictate, but that in many ways shape the conditions of possibility that people can access in their lives and their ability to access health and well-being more broadly. Structural vulnerability. So again, framing, moving from, conceptions of cultural competency or and thinking about structures and what makes people who are positioned within, our society, more vulnerable than others to social harms, and this includes structural racism. And I would posit that harm reduction is a model. It's not a complete, panacea for many of our ills, but it's a community-based model that comes from people who use drugs and their allies from the 80s around the HIV epidemic, and ways that we can take care of each other without involving the carceral system. Next slide. So an entree to some harm reduction strategies that we use. And, I think offering these programs in New York State, for example, there's drug user health hubs that offer all of these services. If we're able to offer these and take care of people in the community, we can envision decreasing the carceral footprint of places like Rikers Island. So when I was there, many people would say, well, abolishing Rikers is great, but where are people going to access the medication that they need, that they get started on in Rikers? And I said, well, how about a health hub? How about a drug user health hub that are funded from New York State Office of Drug User Health? And so it's amazing to see that we can have these, and we can have one-stop shops for people in the communities where they live to access mental health treatment, groups, sterile syringes, equipment, a pharmacy, whatever they might need. And I think that's the end of my slides. One last slide. So again, some of my big ideas as we zoom out for thinking about community efforts, and I think we'll hear about this from the next two speakers, but again, specifically calling out racism, recognizing that these dangers and harms of criminalization. Many people say things like opioid withdrawal is not deadly. It's deadly if it happens in a prison and jail where you're not treated, and people feel so bad that they are at risk of harming themselves. So really, I think taking, while we try to improve the systems that we have, the carceral system is just so fundamentally flawed at its base. And I think really putting all of our efforts and divesting, money into communities is where we should be going, and meeting people where they're at and not leaving them there. So I'll hand off to Leah. Thank you.
Great. Thank you, Kim. I really appreciate your remarks. I'm just going to get this going. Okay. Thanks, everyone, for joining today. I want to widen the lens a little bit from Kim's remarks and think about stages before incarceration. So police contact, arrest, court involvement. Much of what I'm going to talk about today comes from a multi-city study of misdemeanor arrests that was funded by the National Science Foundation and involved collaboration with my close colleagues, Michael Compton, Amy Watson, and Jennifer Wood. So what are we talking about when we talk about criminalizing mental illness? What does that really suggest to us? We generally use this sort of language when we refer to the overrepresentation of people with mental illnesses at all stages of the criminal legal system. And Kim has talked about the consequences of that process in terms of exposure to violence, disrupted medical care, and other adverse consequences like overdose and death. When we criminalize mental illness, we use the criminal legal system to attempt to address the behaviors and needs of people with mental illnesses and their psychosocial circumstances. And this slide shows a number of things that this process has been linked to, including deinstitutionalization, the lack of accessible mental health services in this country, the fact that police officers continue to be the first responders generally to people in crisis and often have limited options for resolving situations, and then the broad array of social disadvantages that both people with serious mental illnesses and people committing crimes are more likely to experience, things like poverty, unemployment, and housing instability. And I think this point is key because it gets us thinking about why criminalization is occurring. Is it a response to the actual behaviors that are related to mental illness, or is it happening in part because of a wider set of social, economic, and circumstances and poverty? So just want to give some context about arrest to give you a sense of the numbers There are around 10 million arrests in the United States each year. The vast majority of these are for low-level offenses, things like disorderly conduct, drug abuse violations, other misdemeanor charges. We'll talk a little bit more about what these look like among people with mental illnesses, but generally, this people with mental illnesses are getting arrested for the same types of low-level charges as those who don't have mental illnesses. In terms of available research, it suggests that up to 10% of police contacts involve a person with serious mental illness. Again, speaking to that overrepresentation, since there are about 5% of people in the US who have a mental illness. We also know that upwards of a third of people with serious mental illnesses have police involved in their pathways to care. And more troubling is the data on police shootings. So we know these encounters can be fatal. It's estimated that about 25% of people who are fatally shot by police have a serious mental illness. One recent study showed that having a mental illness was associated with a 7 times increased risk of death as a result of police intervention. And of course, not surprisingly, there are racial disparities in this data. So the same study showed that the rates of death were highest for African Americans with mental illness. So I want to turn now to talk about our National Science Foundation study. So we know that people with mental illnesses are overrepresented in the criminal justice system, but we actually know very little about the specific charges that people with mental illnesses are being arrested for and how those charges are processed in different contexts. So our study really set out to find more information about the specific charges that people with mental illness are being arrested for and how, when, and why those charges are being used. This was a mixed method study, so we used quantitative data analysis as well as systems mapping, focus groups, and interviews. I'm going to talk a little bit about our findings now. So in terms of our quantitative data analyses, we actually did 2 separate studies, one in Georgia and one in New York, and I'll share some information about the Georgia study. This was a secondary data analysis of 240 participants with mental illnesses who were recruited from inpatient facilities in Southeast Georgia to participate in a new model of community navigation. With participants' consent, we received rap sheets that contained their lifetime arrest and charge data. And we found that 71% of the sample had been arrested in their lifetime at least once, and the mean number, the average number of arrests for this group was 8.6. I want to show you here the charges, the most common charges that they were arrested for. We extracted the participants' first 2 arrests and their most recent 2 arrests to create this list. And you can see here, not surprising to us, most of these charges were for misdemeanors. Only about half of the sample had ever been arrested on a felony. And the top charges, the top 3, you can see criminal trespass, willful obstruction of a law enforcement officer, which is essentially not following the directions an officer is giving you, or disorderly conduct. Some of these charges changed over time, which was interesting. You can see here, we compared participants' earliest 2 arrests, which occurred on average around 20 years old, to their most 2 recent arrests, occurred later, 33 to 35 years old. And you can see how the order of these charges starts to change around a little. So marijuana possession charges drop down lower in the list. Disorderly conduct charges come up towards the top of the list. Some of these variations may certainly be related to changes in policy and practice and how charges are used over time. But it's also interesting to think about how these charges could be related to changes in illness severity over time, or the fact that as more charges accrue, certain charges will become more common. So failure to appear in court, probation violation, those are charges that come from past or current justice involvement and kind of accrue over the lifetime. So I think more research is really needed on these dynamic relationships. I'll move now to talk about our next phase of the study, which was system mapping. And I'm showing here 2 very complicated snapshots of system maps that we created. We worked in Atlanta, Chicago, Manhattan, and Philadelphia to really look at how misdemeanor processing happens. What happens when someone's arrested on a misdemeanor charge in each of these cities? And what happens specifically if they have a mental illness? So our aim was really to identify shared contexts for how systems intervene in the lives of people with mental illnesses, We brought together stakeholders in each of these cities to create these maps. So we had mapping sessions that included prosecutors, police officers, public defenders, nonprofit organizations, and mental health providers. And we mapped out, as you can see, the really complicated ways that misdemeanor processing can happen in these cities. We found that the systems all shared a commitment to changing how people, how misdemeanor systems intervene in the lives of people with mental illnesses. But we also found that there was a lot of context that influenced decision-making. And this visual is an attempt to explain some of our thinking around how we think that this is happening. So you can see at the center of any incident, this incident surrounded by a series of decision makers, police, prosecutors, defenders, the community. And those decision makers have opportunities to leverage different interventions to create off-ramps for people with serious mental illness to get out of the criminal justice system. So they might leverage crisis intervention teams, crisis triage centers, police-assisted diversion. So they have an opportunity to use those interventions. We also found that their decision to use any of those interventions or traditional criminal justice processing depends on larger contexts. And we highlight 5 here that we think are critical. First, the law and policy environment clearly determines how any of these actors act. As an example, COVID-19 changed how arrests were made. Bail reform in New York State has changed which arrests are eligible to go to jail. We also know that the location of the behavior matters. So there are different behavioral norms operating in different contexts, and people have different understandings of what counts as acceptable behavior in public places. Closely related to the location is the expectations of stakeholders. So complainants or victims might be involved in any single incident and may have different expectations for what they want police and other criminal legal stakeholders to do. We know access to community resources makes a difference. So whether someone thinks that they have options for referral to a community resource may determine what they do in a given situation. And finally, knowledge of a mental illness. Do the different stakeholders know that a person that they are potentially arresting has a mental illness? And if so, how do they use that information? So this point about the extent of knowledge around mental illness is the last point I want to expand on. Because in addition to the 5 contexts I've mentioned that shape decision-making, our study also revealed that decision makers come to the table with different values. This value pluralism, so to speak, complicates efforts at system reform because it suggests that there are multiple and even contradictory ideas about how to achieve the goal of getting people with mental illnesses out of the criminal legal system. At its core, this involves questions about how decision makers understand the relationship between mental illness and crime and what they believe the role of the criminal legal system is in connecting people with treatment. And so I want to end with 2 quotes that speak to the challenges, to the differences in approaching this same goal. So on the left side, you see a quote from an assistant district attorney who's talking about the benefits of treatment court. He says, one of the benefits of the treatment court is we won't have to actually prosecute them in trial and have them found guilty. We can keep them in the court system. We're kind of that middle ground and say, I want to keep this here for a while, have them engage in treatment, come back to you. And at the end of the day, we all get what we want, or hopefully this person will be in a better place and will continue to take their medication, and at the same time, not have a criminal record as a result. So that compared to what a public defender said, who says, I don't like bringing a mental illness to either the prosecutor or the judge because it depends on what you believe about state intervention, but they usually make a lot more requirements of people. If there are more resources to help them, maybe they could think of a better way to help them. But usually it's no better than when they walked in that door, and usually worse. So you can really see we have 2 approaches. On the one hand, we have the ADA who's thinking about how to use the criminal legal system to leverage treatment opportunities. On the other hand, you have a public defender who talks about how treatment through the criminal legal system is often more punitive than traditional case processing. And he's reluctant to bring that up in a misdemeanor case. I think these quotes really speak to how siloed the criminal legal system is and how useful it would be to bring people together to jointly examine some of the values and orientations that shape their work, and then use that shared understanding to develop cross-system ideas for improvements. I think I'll end there. I'm going to stop my sharing, and I will pass it over to Faye. Thank you.
So, good afternoon. My name is Faye, and thank you for having me. That was a lot of information from both ladies, and I'm usually like a devil advocate, but I just find that I was looking at some of the questions and some of the comments in the chat, and from my experience, it's always about race, environments, what people perceive, right? And everybody's never going to agree, but what is really important is that we gather together and find a resolution, right? I'm not picking nobody apart. It's about figuring out a way as a community to come together and uplift people. That is the plan, and it should always be the plan. And sometimes police are not available for the plan. Peers are necessary. Based on my own experience with incarceration and being misdiagnosed and not being diagnosed and still, right, productive member of society and still not getting the proper mental health or medical care, that you say this is the land of the free. Well, freedom ain't free, ladies and gentlemen. It's not free for people that look like me. And it's about race. It's about how opportunities are different for people, right? How they have zip codes that police are responding already with a perceived notion that I'm gonna bang some heads and, Brooklyn, Bed-Stuy, right? The rate of police contact is high. East New York, Brooklyn, Canarsie, Brooklyn, certain parts of Manhattan, Upper East Side, like in East Harlem, Spanish Harlem, the block I live on. So my hope is that as we sit here and speak about the horrific treatment of humans, that we can come to a conclusion on how we can now start again, right? And keep staying in that same focus lane of how do we make better treatment for people, right? Better education for people, Black and brown people. I'm gonna say it, I'm sorry, but it has to be said because we're the ones losing the battle the most. And I'm gonna stop right there. And I'm gonna pass it back to Tiana. I'm only guessing.
Great. No, thank you, Faye. And I'm going to ask Leah and Kim if they could come back in terms of their camera. And Faye, we'd love for you to join as well on camera. And thanks so much to those who are contributing questions. I promise that we're going to get to as many of those as we can. And also, if you've put a question in the chat, we would love for you to move that over to the Q&A box. But please feel free to use the chat as a way of sharing resources and communicating with others in this audience. And I think we have just a very large and rich audience with a lot of wisdom in the room. So I really encourage you to ask questions of our panelists. So thank you so much for those presentations. And I would love to start off with a question about harm reduction, actually for all three panelists. Kim, you started us off by talking about a harm reduction model and various strategies that could be useful and impactful. I'm wondering if all three panelists could to speak to that idea and ways in which that provides a set of actions in terms of trying to mitigate harm. And maybe we could start with you, Kim, if you don't mind.
Yes, thank you so much. So I think, I think sometimes I want to have these big picture questions, like if you had, $100 million to implement, a program, what would it be? And I think that we have decades of evidence that harm reduction strategies are evidence-based and really can, meet people holistically in their needs. And so it's not only access to safer supplies to prevent transmissible infections, but really even thinking about preventing the harms of criminalization. So, for example, when we talk about overdose prevention centers or supervised consumption sites, which are a harm reduction strategy to have trained people around in a facility where people can use pre-obtained illicit drugs in that facility and receive attention and care for an overdose. Even thinking about working for those sites and advocating for those sites around the country, which are happening in states all around the country, Colorado was trying for them, Rhode Island has the first state sanctioned one coming early 2024. New York City has 2 already that have 2 above ground sites that have been operating in Washington Heights and East Harlem. So these sites also protect people from the criminalization and being beat up by cops, having a safe place to be, not to be assaulted, and to not die. I mean, to receive overdose support. And really, when you go visit these sites, you realize that these sites there's no magic formula, but they're doing what people want and need and providing people with basic things like food, places they can wash their clothes, medical care is there, wound care is there. It's not, access to groups and other forms of alternative healing like ear acupuncture, things like that. So it's what the community asks for, and these programs, when I talk about them to some audiences, I'm like protecting people from being killed by police, right? We know that people who are intoxicated or on substances have been killed, right, by police. George Floyd, many people, Rayshard Brooks, many people of color, Black people are killed when they're intoxicated, and that's unacceptable. So that violence, even thinking about ways that we can use harm reduction and think about harm reduction, incorporating it into different spaces to protect people and keep them alive and well.
Great, thank you. Faye, can I go to you? And you've been doing such incredible work with the Urban Justice Center, and you have advocacy workshops, both thinking about it in terms of system level issues. What does harm reduction mean for you and your work?
I think harm reduction is a two-way street. We can provide ways for people to safely meet a goal. Everybody doesn't want to stop using substances, but harm reduction is a way that you can move that person maybe towards recovery, right? But recovery is what that person thinks it is, right? I can't tell you how to recover, right? And when I say it's a two-way street, a person has to engage in that, right? We can have all the harm reduction in the world, and if people aren't open to engaging, right? Because harm reduction speaks to a safe way of using. Let's just call it what it is, right? It speaks to a safe way, but you want the end result to be that person free of drugs, but that person has to want that. And that's where it's difficult, right? So in the work I do, I build rapport with people, right? I disclose a little about me so that they don't think they're sitting in front of somebody that don't get it. So yeah, it's a two-way street. And if you build a level of trust, then that person might start off with, I'm only going to use this much. But because of some of your input and them now trusting you, right? Being safe with you, now they're saying, yo, Faye, man, I only did one bag and I feel like I could stop. And there goes a resolution and harm reduction, but it only works if that person wants it. So all the resources in the world, right? But if that person is ready, then we got to win. And that's what the plan is. In the work I do, I try to get a win. If it's only one, it's still a win.
Okay, great. Thank you. So Leah, I want to go to you too. And I actually want to tweak the question a little bit because I want to take advantage of your vantage point, because you really are at the intersection of the legal and the medical world, both in terms of your work and your research. And I'm just wondering if you can talk a bit about the model of harm reduction or the goals around harm reduction as it relates to these two different systems that come together and really have an impact on whether or not these proposals can actually take off.
Sure, absolutely. So I think a couple of things, the model of harm reduction obviously kind of is centered in the health world. But I think increasingly we need to think about it, how it can be used in criminal legal systems so that criminal legal system stakeholders adopt a philosophy of harm reduction in their work. So Kim and Faye, spoke about different options that we have. We have evidence-based solutions to respond to people who use drugs. And we also have ways that we can criminalize people who use drugs. When police make decisions to arrest people, when prosecutors make decisions to charge people on drug-related charges or incarcerate people, those are decisions that lead away from harm reduction models and towards criminalization. So that being said, I think there are criminal justice system stakeholders who are starting to adopt a more harm reduction approach. There are good examples in different places across the country that could be adopted. But I really think, widening our perspective on what should be available in the community, moving away from the idea that people need to be incarcerated to receive treatment. We know that going to jail for substance use treatment is not the solution. Is really, we need to promote those models and make them accessible in more places.
You mentioned community, and I know, Kim, you also, your last slide, which I thought was so important, really focused on community-driven efforts, things that can be helpful, good strategies to try to intervene on this process. And, I'm trying to understand at the institutional level, places like Yale and Columbia, what can institutions do to strengthen these efforts? Are there things that you've learned that are really critical in order for these big academic medical centers that are located in places where there is this kind of criminalization of mental health and really in terms of some efforts around creating relationships with communities and trying to fulfill some of the things that you outlined in that last slide? What can institutions like ours do?
Well, that's a big question. I recently read this book by DeVary Baldwin called In the Shadow of the Ivory Tower: How Universities Are Plundering Our Cities. And I would recommend that we all read that and think critically about the history, interrogate the history of our institutions trampling on our neighbors. I think, but I think there's many ways that DeVary Baldwin and many great people and thinkers have thought about this. I know that Yale was pretty instrumental in conducting some of the research. If we're thinking about the research capacity that we have and the ability to bring evidence forward for alternative models, I think, we all believe in the value of research. So the value of syringe service programs or needle exchange programs, many people, associate some of those programs coming up and being studied out of Connecticut and out of New Haven. And so, working, but also at the same time, working with practitioners, legal practitioners, many nurses and doctors went down and got arrested in the fight for needle exchange in New York City in the Lower East Side. So civil disobedience is something that I'm always, I'm not necessarily promoting it, but I have done it in the past personally. But, I think institutions really need to reckon with our histories and really think about, our communities. In New Haven, there's a very, it's very segregated, thinking about how services, where services are located, really being attentive to the needs of particular communities and those histories is important, not just tokenizing people, but paying them for their expertise and bringing them on to more than just community advisory boards, really in a meaningful way, co-constructing knowledge and research together. If people want to do that, there's a lot of ways, I think.
Mm-hmm.
Just gonna add 2 points quickly to that. One, I think in terms of training and education, I think there's a real gap in health education around the criminal legal system. It is not a standard part of medical education, and it really needs to be, because we know the harms of the system from a health perspective. So I really think for people who are in positions who train other people, really thinking about how we can, make changes in the education so that social determinants of health, like incarceration, are really a central part of the curriculum. And then the other thing I think that can be a challenge to universities is really to think about how we design and implement research studies, kind of echoing the last point Kim made, that there are many more opportunities to engage people with direct experience and system involvement in the way we construct and design and implement our research studies, so that they are more responsive to those communities.
Okay. Faye, can I ask you, I think we have many medical students in the audience, and I'm wondering, given your work in advocacy, is there a place or space for medical students to be active in advocacy?
Absolutely. There's spaces for everybody. Like there's in advocacy, there should be no discrimination. There are going to be times where people are not going to agree. But if we're putting something on the table that's important and passionate enough for everybody that wants to be involved, then the result should all be the same, right? We resolve into better for something. So medical students absolutely should be involved, right? Because now you get to learn something outside of you, right? You get to like they always say, you never know who's listening, who's looking, and who's in the audience, right? And I encourage people that have a passion to speak your passion, right? It starts with one and turns into millions, right? But protesting ain't enough. You need to know who your lawmaking people are, your councilmen, right? Stop voting for president. President is not the most important vote. That's not where the people that make the laws are at, right? You have to be registered to vote and vote for these council people and change the format of who the district attorney office belong to, that's how you can get involved, right? You register to vote, know your councilman, get into community boards in your neighborhood. Takes a village, right? Know your neighbors, right? You can go into your precinct and speak to the captain. You can be there's a lot of different ways to be involved, and I'm getting excited, but yes, those are some of the ways they can be involved.
Fantastic. We did have a number of questions that came in through the registration. There is one question that I think follows from what you've just said, Faye, and it's a question about Mayor Adams' plan for improving the mental health system in New York City, especially with respect to homeless people with serious mental illness. And I wonder if any of you want to comment on the mayor's plan.
So let me go first, please, ladies.
Sure. Yeah.
That is not a plan, right? God always say, if you think you got a plan, let him know. But Mayor Adams is the police. Let's just call him what he is, right? He's the police. So how can there be a plan to literally snatch people off the street without their consent? And right, because that's one trauma. Then you put them in a mental institution. That's trauma too. Where was their voice in that? So yeah, I ain't vote for Mayor Adams. I'm sorry, but I'm on the record as saying that is not a plan that I'm in agreement with.
Leah or Kim, do you have comments?
I'm happy to add to Faye's comments. So, I think obviously the plan has been very controversial, and I think most of it is focused on kind of whether he's expanding what already exists on the books in terms of the law in ways that go beyond the law. But I also kind of want to make a more practical point, which echoes what Faye says in terms of I just don't think it's a plan. I think it reinforces what has already been the case. There's already involuntary commitment laws. But a couple of things that I think are worth noting. First, police can take someone to the hospital, but it's only doctors who can actually make the decision to hospitalize someone, right? And we know that emergency rooms are already stretched beyond capacity. So if the mayor's mandate doesn't come alongside more funding for psychiatric beds or services, it's really hard to see how this is a plan. People will either not be admitted, or they'll be admitted and discharged without appropriate services. And you can see kind of a predictable cycle happening, which ultimately I think leads to police not even moving forward with this order because they're going to feel like it's pretty ineffective to bring someone to the hospital who's then quickly released without appropriate services. So I agree with Faye that I'm not sure it's really a plan at this stage, and doesn't address the much larger issues that we have a major problem with housing that we need to address.
Kim, I wonder if you could comment just in terms of that, what Leah has laid out with respect to pressures on the clinician and the kinds of accommodations that they're able to make, but at the same time they're kind of in a tough position, right? In terms of addressing the needs of people that are coming in the door, but then not having kind of a system to rely on. I don't know if you can speak to any of those factors.
Yeah, I mean, I was just in the hospital last week at Yale on service, and I can only speak to I'm in and out of the emergency room for substance use calls. But what first of all, to Faye's point, without people's consent is critical, and this issue of involuntary commitment comes up all the time for both substance use and it's basically like homelessness, who even knows if someone has serious mental illness or not. It's really when you receive someone in the emergency room, there's a really it's a stabilized and out again. I mean, there's some of the hospital systems are working on addressing structural determinants of health, but that can happen in the clinic, And for example, you've had on your webinar, Emily Wong from the Transitions Clinic, which is a primary care clinic for people leaving prison and jail, people with substance use disorders, a one-stop shop. I would suggest looking up that model and using peer navigators, using community health workers, people who have lived experience of incarceration and substance use, to address those structural and social determinants of health before someone's in the ER, right? And the ER is a really inappropriate place for those resources. And you can't really be thoughtful. I would much rather see you in clinic than the emergency room, where, you don't feel good and you don't want to be there. And I don't want you to be there either. Many people feel like the hospital is jail, okay, right? Jail and prison, right? Let's be clear that for a lot of people who experience structural violence, it feels like being incarcerated. There's much qualitative, research about this. And so that further perpetuates the problem. If my ability to help you is because I'm a doctor in this jailing system that harms you, it doesn't feel good. It doesn't allow us to have a therapeutic relationship like I can have in the community. So those are just a couple of my thoughts, but yeah, we, there's so many easier, more humane ways to address the issues that are causing people to not be well.
Mhm.
One quick comment.
Yes, Faye.
Like what Kimberly said, even if the police bring you into emergency room, it's still right now the doctor looks like it's part of the plan too, right? Because already in my mind, just like you perceive a notion about me, now I perceive something based on what you've done to me. So now me coming into a hospitalization environment, I am not cooperating because from the gate, nobody cooperated with me.
Mhm. So it's this kind of long-term relationship with the healthcare system, with various systems. Is that what you're saying, Faye?
Yeah, because you got to remember, we're talking about, see, they're already saying what people are before you ask these people what they are. Nobody is speaking to people like they're people, right? They have these initials that they put on people with mental health concerns. How fair is that? That's still, they have initials they use for people that wind up in the prison system. They're still people. Stop numbering people. And if you talk to people like they're people, you might get a better response. Some of the things that are happening might not happen, but you are not taking that. You don't use any other option, but you just go in like gangbangers. Come on, man. They're still people, and everybody ain't wired the same. But if you're kind, right? If we start being more of a kinder nation or kinder people, we might get a different response as opposed to violence on violence.
Mhm. So this not giving people respect and treating them with humanity, but having these preconceived notions of who they are, why they're there. It strikes me, actually, this reminds me of the incredible data that you've generated through your studies, Leah. And some of the findings around, how, when, and why somebody might be charged. And I just wanted to give you an opportunity to talk a little bit more about that in terms of what that means for how we move forward, or how do we intervene, knowing those patterns.
Yeah, so great question. So I'll say a couple of things. First, I think it's important to contextualize that the study that I spoke about was done in 4 pretty progressive places: Atlanta, New York, Chicago, and Philadelphia. And Philadelphia maybe being kind of the best example of a progressive prosecutor's office and how they've really changed how they make decisions around charging, right? So, as I said, different decision makers have discretion at different points. Police have discretion to make that initial arrest or not. then it comes to the prosecutor's office where again, they can decide to take the police officer's charge or downgrade it or upgrade it or dismiss it. So people have these decision points and power to make one decision over the other. And in progressive places, we've seen prosecutors' offices, for example, saying, I'm no longer charging this sort of crime. I'm no longer, and what happens then is that puts downward pressure on police to no longer make those arrests because police know that they're not going anywhere, right? So I think, you know, in terms of policy and practice, we can kind of see as, you know, different influential stakeholders make decisions about how they're going to charge or not charge certain things, that can put kind of a positive pressure on other system stakeholders to act accordingly.
Great. All right. Well, I'm going to turn to the very long list, which is wonderful, long list of questions that we've gotten from our audience, and actually return to some comments earlier in our discussion that relate to Shrava's question, which is the most highly voted here. And it really does go back to what can be done for medical students. This person writes, you know, can you speak to things that can be done by medical students who believe in abolition and decriminalizing medical health, but are forced to continue to learn and work within very carceral medical industrial complexes that values policing? And, you know, maybe this speaks a bit to, Leah, you mentioned in your talk, the competing values of various stakeholders, and how do you start to really kind of change the ways in which people are being taught and function and practice, given the values in which we do our work? Yeah. I don't know, Leah, if you want to go first, or if Kim.
Yeah, so I think it's really challenging. I mean, I'd be curious to hear what Kim says as like a medical provider. I think that, you know, physicians constantly face issues of dual loyalty in this sort of work, right? They may work for big hospital systems or may work in jails or prisons, and yet their primary responsibility is to their patients. And so I think, you know, again, bringing back to kind of training clinicians for these sorts of complicated situations, how to navigate these power dynamics and make decisions that are best for patient and clinical care, even if that means, you know, speaking up against institutional practices is really important, right? And so these sorts of conflicts are part and parcel of being in this line of work, and I think people need to be really conscious of that. I think, you know, the other thing, just I guess to your point, Sandra, is I don't think we have enough cross-system collaboration. And the result is that, you know, we're operating from assumptions about where people are coming from, rather than making explicit kind of what orientations and priorities people bring to the table. And I do think that there is value in kind of thinking of these negative outcomes as sentinel events, so to speak, and really trying to do problem solve around how do we prevent these bad outcomes from happening? What do different stakeholders need to move forward with certain decision making? What's on the table, what's off the table? But too often we're so siloed, and the medical and healthcare world is really not even at the table in these conversations.
Yeah.
Well, I think about this constantly. I did not necessarily feel empowered as a medical student. I went to Harvard, and I did not have a theoretical or like a framework for abolition. I was pretty like meek, honestly, like it's so hierarchical when you're training. So already the fact that you have a sense of how wrong these systems are that we interact with is really, you have a leg up on me. And I would say things like, no matter where you go into medicine, I'm working on a paper with some surgeons about like getting cops out of, gunshot wounds, and like getting cops out of the operating room, and like taking up your space, and like knowing your rights. Like that's some basic stuff. Like I kick out, if someone's in custody, I kick the officer out, like you need to know those things. So there's been a couple webinars, one at Yale, the Solomon Center, and one at Penn, the LDI, about like what that actually looks like practically if someone's, in custody, providing them the care that they need, advocating for them. So I think on like the clinic level and the hospital systems level, there's a lot of room, like even thinking about things like and I think writing is really interesting. So when I was in training and as a medical student, I wrote a lot. I think writing about your experiences can be really useful, and it can be really helpful and both therapeutic. I said, like, why are we like, treating someone who overdosed in the bathroom like they're a criminal? Like, what's our policy on this? Or like, how can we work with nursing? And like, this is very, very common, and there's no policy, and the policy just ends up with people huffing out and people being attacked and accused and searched and treated like they're, like they're not human. And of course they want to leave. Of course they don't want to stay to get treatment for their infection. So I think there's micro level stuff you can do with patients, and for medical students, I always say, like, you can use some naivete and be like, why is this? Like, why are we doing it this way? And is there evidence for this? And like, is there a protocol, or can we change this? So using that naivete is a really useful approach. But, taking it to advocacy, like Faye said, I was testifying at the Connecticut State House for overdose prevention centers, and knowing that my patients are affected, I waited like until 12:30 a.m. to testify. I was like falling asleep, but basically I'm like, this is like, if I could have this one thing, I would prescribe it for my patients. Like I'm seeing all this stuff come with me to the hospital, and so that your voice is incredibly powerful. So leveraging your privilege and working with communities, I think I brought patients to to grand rounds on teaching harm reduction. Patients are the experts. Patients with lived and living experience. So like, there's a lot of stuff you can do, but it's really exciting to hear all of your ideas.
That's great. Yeah, I mean, I'm very struck by your suggestion that naivete is a powerful tool, like asking questions, seemingly basic questions about why a problem is framed the way it is, I think is a wonderful approach. So we have a question here from one of our attendees, and Faye, I'm going to go to you on this one, but I'd love to read the entire question because there's a lot here. So this person writes, I believe there is a deeper problem at hand than fixing a system. Society needs to have more exposure to the mentally ill and be required to learn to accept their behaviors if they are not harmful to others. We accept diversity of all kinds, but the unique communication and behavior of some mentally ill people makes others feel uncomfortable and results in overt discrimination. Over the years, I have seen many cases in which the police are called because a community member is quote unquote concerned about someone they think is mentally ill. Individuals who call the police when there's no need should be held accountable. Why is there no dialogue that focuses on the discrimination that drives arrests? Really interesting question.
So that's a lot. But,
Yeah.
So people with mental health have been discriminated for years, and for some reason they're now in this light because of our last mayor and his daughter battle with mental health. So we have been, people with mental health, me included, have been thrust into a limelight. And the community person that calls, I think that if I live in your community, I said this already, y'all need to know your neighbors, right? If we in this community, Like, I have this coworker, Dr. V. She's the greatest community organizer in the world. Shout out to Dr. V. And it's always about community, right? And the minute there's a mental health call, whether that person is dangerous or not, they are going to respond like that person is dangerous. And that part of this response needs to be fixed. The call go in and police are not trained. In that minute, right, that's when the education needs to begin, right? So that when the call does come in and an officer get it, he might say, yo, let me call a peer to take with me. Right? But the neighbor being punished, I'm not too sure that is a good deal either, because now you have to remember you're destroying more than one family, right? And if we're talking about community, we're trying to see it from this person's point of view, and the lack of education of people that you live with will sometimes get you in a situation that you shouldn't be in. Because again, the stigma on mental health, see, that's where it starts at. It is not even, I'm crazy, right? It's the language people use with people that have mental health concerns. And if you see me acting erratic, instead of trying to figure out what's going on with me, you assume, right? Y'all know what that assume thing means, right? I'm not going to say it, but you assume that I am de-escalating, right? You start using all these negative words when you categorizing me as a human, right? And it goes back to us being kind. So I think that a lot in that question, that if we're not kind and we don't educate, then we're going to have more of these kind of situations take place. So the bottom line is that all sources involved, right? It should be prevention, right? We should always want to try to prevent before we intervene, right? So I think that to wrap it up, right, in a bow, is that everybody needs to be educated on how to respond to people. I'm not going to say people with mental health, people, because everybody got a mental health, right? There's no perfect brains. There's a chemical dysfunction in all of our brains, and some of us show it more than others, right? Or some of us show it at night when no one's around. People don't think in that terminology that I'm still human and I just need help, assistance. I don't need to be caged up and medicated, because sometimes that ain't the answer either, right? I know that medicine is always, but I heard one of my panel members say holistic, right? We got to educate people. And if we got responders, then they need to be educated the most and sensitized, because the old guard ain't changing, right? And they teaching the ones that's coming up behind them the same old boy redneck stuff that they're doing over there in precincts and in correction facilities as well, and institutional facilities too, because there's an old boy club in these mental hospitals as well, right? Because we already said that this person is this, and this is how we're going to treat them, dehumanizing people all around the board. So I hope that I somewhat answered the question.
Yeah, it's a big question. Thank you. No, thank you so much, Faye. So there is a question here from Cynthia Desmond, and it's for you, Leah. She noted your quotes from your presentation from both a DA and a public defender. And she's asking, what does the data show about criminal defendant satisfaction or dissatisfaction with mental health courts? Could you answer that question?
Sure. So, our study wasn't focused on mental health courts per se. So I'll speak a little bit generally about what we found. I would say overall, the specialty court research is hard to come to conclusions about because different courts operate with completely different models. So it's really hard, I think, as a researcher to draw conclusions about kind of what models work. Mental health in one court is not the same as mental health in another court. There are lots of different versions. Some only take misdemeanors, some only take felonies, et cetera. And so I think what works for whom and when is still an open question that we need to study. I think there's some evidence that some people find the structure of mental health courts helpful. And then there's also a lot of evidence that some people find it inappropriately, extending the mandates of the criminal legal system in ways that are much longer and more intensive than would have been required if they had taken a plea to a guilty plea. So lots of examples in our data from people with mental illnesses saying that, particularly for low level charges, and I think the calculus changes when people are facing higher level charges, but for low level charges, there's very little incentive to say, rather than pleading guilty and getting time served, which means I'm going to be out of the criminal justice system today, even though I have a guilty plea, I'm going to agree to be in mandated treatment for a year. Yes, it gets me treatment, but two things. One, quality of treatment is still, so below where we need it to be. We really have, I think, a parallel and much less well-resourced treatment system for people with criminal justice system involvement. And then two, if you're under that criminal justice mandate, then you're being supervised by the criminal justice system during that period. So any sort of failure, so to speak, gets you re-entangled in the system. So I think people often feel like the consequences are too high for any sort of mistake, even if they want to have treatment. So I think it's a really complicated relationship. And I think more research is needed on exactly what works for whom and under what conditions. It's a great question.
Mm-hmm. Good. All right. So Ezra Susser is asking us to focus on housing and writes, housing first was noted as a form of harm reduction, but is not being implemented in the USA, though it is in other countries. And unless people have a dignified place to live of some kind, how can the other interventions work? This is also an aspect of racism, since racism also largely determines who becomes harmless. I think maybe homeless. The provision of housing is not an intractable problem, but simply reflects a lack of political will, in my view. What are your thoughts about this? So here really focusing on housing as being a major driver in this case. And I'm just wondering, does that resonate with you? What do you think about this question?
All right, I'll go first.
Yeah, thanks, Faye.
So I understand that people need a place to stay, but there's steps like something rings true to me, right? You mumble before you talk and you crawl before you walk. And like with anything else, it's a process. So you put somebody into housing and they don't know how to pay rent or buy groceries, adult living skills, right? They don't know how to stay clean. So they're back outside, right? They have lost this place. So people always want housing, but you have to know, you have to practice being responsible at some point. You get the housing and you lose it and you right back out, but then this process starts all over again. So yes, people need housing, but people also need to have a process of steps taken so that they can keep the housing, right? So there's the interview, right? There's hygiene matters. There's like when I did a 20/10 for one of my participants, and it went through, and she's housed, right? But in the process of that, we went through some stuff, right? We practiced some stuff. We practiced her body language, right? We went and we got her interview clothes, and we got, we didn't dress her up, but we just got some stuff out of her that was in her that had got lost in the process of being homeless and being addicted on methadone and heroin and things of that nature. So when we did get her apply for housing, she was ready, right? And the goal is for her to be happier than me, right? So I have to disclose some of my history on how I wandered up in mental health housing, which I'm still in. But you want people to be excited about housing, and then you want them to be able to keep it as well. You don't want them to lose it, right? And go back into that state of depression and like risk to failure type of thing happens. So you want people to be prepared to keep what they are asking for. And a lot of people ask for housing and they're not prepared. And that's the truth of the matter. And I'm not trying to be harsh or nothing. I'm just explaining my experience with my participant. So I hope that was a little bit of something that can be taken into heed when that question arises.
Great. So we only have a few minutes left, and we do have a lot of questions, but I wanted to end on kind of thinking forward. We did have a question that came in during the registration period that asks, this question about your vision for what mental wellness systems could be in 25 years from now or sometime in the future. What is your sense, or what is your vision? And I imagine that there are things that would have to change, but what would be your vision of a wellness system 25 years from now? Yeah.
Not gonna keep putting me out here sitting there grinning and chilling and stuff. Almost made me use a bad word. So I think that in order for a vision to work, it has to be educated, it has to not discriminate, it needs to be kind. If we are not going to use and treat people in a manner that uplifts and empower them, then the vision don't make no sense. You gotta treat people like people, man. And yeah, we're gonna need some money and all this fabulous stuff, but if we get the resources, then we got to think about who we got in charge of these things. And that person, right? That CEO, that CFO, that person has to then get groups of people together that are thinking in the same wavelength. Now, I could be in Fantasy Island, right? Because y'all said the future. So my hope and my wish is that building that type of resource that's available for everyone, regardless of race, creed, mental health, regardless of that, with some amazing people that have some compassion and a heart for human beings, then I'm with that. And that probably could happen last week, but you know how this world operates. But that would be my envision for a future that loves people, that really, when they say that the money shouldn't change them, right? Because we're going to need the money for the resources to have things that are available. And this sounds like a fairy tale and a happier ever after. But it's possible, because if humans just change and stop trying to climb and be crabs in a barrel, we could probably win something really fantastic. That's my hope.
Thank you, Faye. Leah or Kim?
Sure. Thanks for that, Faye. I think obviously a lot of work to be done to develop an accessible and acceptable mental health system. But the question I think you asked was a mental wellness system. So I think this, to me, speaks to something a little bit broader. I think we know that mental health treatment is not enough, and that we really need to think about systems that are holistic, that new interventions that address social determinants of health, person level factors, as well as place level factors such as environment, and that we frame our interventions toward recovery. So I think too often when we're thinking about this nexus between criminal justice and mental health, the focus is on, what's going to stop people from engaging in criminal behavior. And I would like us to think a little bit broader to say, not only focus on recidivism, but what are opportunities for people to re-engage in meaningful activities, regain competencies, be socially connected, because I think that, is often overlooked, and really, where I think we can focus on, building better systems that are more hopeful.
Right.
I'll just briefly add on to what everyone else just said. And, I think as a medical provider, as a clinician, we're like, oh, like do all the things for people, get them what they need. But like thriving and well-being, so much of it takes space outside of the clinic, And I think some things that I advocate for is like a universal healthcare system that's, coming up in this Byzantine system of care provision where it's so difficult. Guaranteed income, like if people just had $1,000 a month to like meet their needs, like that would solve a lot of their problems and a lot of why they come to see me, right? I mean, if people had if people had housing and a guaranteed income and could meet their needs, so many of these downstream problems could get prevented or solved. And I think just a thread through a lot of these questions and comments is that people do really well, can do really well. And I've seen so many people get better. Maybe they're not using as much, maybe they're using less, or they're using not at all. And they're just living and thriving. And that message is not heard and it's not seen. And so, we try to have harm reduction campaigns and, people talking openly about their use and openly about, doctors disclosing their health, their mental health issues. And, there's a doctor in California who is the acting, California Surgeon General who is bipolar and is very, those kinds of things, taking these things out of the shadows and just embracing, people's humanity, as Faye has, really emphasized, and embracing, people's differences and knowing your neighbor. I think a lot of these are basic, but we get very siloed and we get in our lane and we stop thinking in a big way. And so I think, taking heed from working, I take so much of my direction from the Drug Users Union, from the National Drug Users Union, so building that community and those meaningful relationships helps us actualize, the future that we want to have.
Wonderful. Well, I'd really like to thank our speakers today. It's been a really rich discussion, and I thank you for your presentations as well. I also want to thank our Ethics Grand Rounds Organizing Committee for their support in planning this year's series, as well as the Division of Ethics staff, Tiana Sepapur, Dunya Alami Nasif, David Lamb, Shauna Benston, and Rachel Yarmolinsky, who have been absolutely critical in terms of putting on this event. We had so many great questions from the audience, and really want to thank all of you for your thoughtfulness and for your engagement today. The recording of this event will soon be posted on the Columbia Division of Ethics website. We hope that we will see you in the fall for our kickoff of Ethics Grand Rounds for the 23-24 academic year. And we also wanted to invite you to register for our next LC Friday Forum event, which will be on May 12th this month. That session is entitled Value and Values in Payment for Gene Therapies. It should be a really great discussion. To receive information about these and other events, we invite you to subscribe to our Division of Ethics newsletter. The link, as well as all the links mentioned above, will be posted in the chat. And then finally, I hope that you will fill out the post-event survey. We take this survey very seriously. It helps us immensely in terms of organizing future events. So please do let us know what you would like in terms of events, and also suggestions for speakers and topics. And then finally, again, just really appreciated that so many of you joined us today. And thank you again to our panelists, and I wish you all a good rest of your week. Thank you. Thanks so much.